So we talked about acute inflammatory response. Let's wrap things up with the chronic inflammatory response. And so this is going to be a little bit simpler in terms of, how much you have to know. You just really have to know some of the big players here. But what I do definitely want to hit on here are going to be granulomas. And so we'll talk about that in a second. But again, chronic inflammatory response, we're usually talking about ongoing destruction and repair of tissues. That's going to be more characterized by monocytes, plasma cells, and occasionally macrophages as well. When we talked about the acute inflammatory response, we talked about things like heat, vasodilation, edema, swelling. We're not talking so much about that with chronic inflammation. This is going to be more fibrosis and angiogenesis, and sometimes calcifications you can kind of throw in there too. But fibrosis and angiogenesis are really the big two components of a chronic inflammatory response. Tuberculosis is kind of like your classic example of this, okay? And so, tuberculosis is where we get into this conversation about granulomas. So before we get into that, the things that I want you to know here, number one, interferon gamma is going to be one of the major promoting factors for macrophages to be pro-inflammatory. Okay, so you kind of think about, a scale of some sort. Okay, so you think about a scale of some sort. You can think of interferon gamma as being on one side of this scale. Okay, interferon gamma is going to be over here. Okay, and so this is going to be pro-inflammatory. And then on the other side of the scale, you can have your interleukin 4 and interleukin 13. Okay, and so these are both going to be anti-inflammatory. Okay, so you have your pro-inflammatory, and then you have your anti-inflammatory. Okay, interleukin 4, interleukin 13 being more anti-inflammatory. And you can see that the pro-inflammatory, right? So the pro-inflammatory response, that's going to largely be driven by T helper 1 cells. Okay, so I'm going to put a T helper 1 cell, and that's what's going to be releasing this interferon gamma. Okay, on the other side of that, the T helper 2 cell, okay, the T helper 2 cell, you can see is going to help decrease the inflammatory response. Okay, so 1, 2, right? Interferon gamma, primarily pro-inflammatory. Interleukin 4, interleukin 13 are going to be more anti-inflammatory. Then we already talked about a lot of the other factors down here that are going to help stimulate the acute inflammatory response, which is not necessarily, going to be the same as what we're talking about here. But we talked about interleukin 1, interleukin 6, and TNF being the big three that are going to kind of kick the party off for an acute inflammatory response. Remember, these are all synthesized by NF-κB, and that would be more of the acute inflammatory response. Okay, let's get back to this slide, though. Don't want to get too off track here. So, again, that's what we just talked about here. Interleukin 4, interleukin 13, decreasing the inflammatory response, and then interferon gamma is going to be increasing the inflammatory response. So these three bullets down here are all really specific to this chronic inflammatory response. Now, what I want to call your attention to, because some of this gets tricky. So FGF stands for fibroblast growth factor. Fibroblast growth factor is not the thing that's typically increasing fibroblast collagen synthesis. The thing that normally does this, that gets asked about, is going to be platelet-derived growth factor. Okay, so this is why this is kind of tricky. The platelet-derived growth factor, remember, is the thing that's primarily increasing fibroblast collagen synthesis. That's what's responsible for this fibrosis that you're going to see. Okay, so that's going to mostly be platelet-derived growth factor, not fibroblast growth factor. Fibroblast growth factor is mostly associated with angiogenesis, and then this one actually doesn't make sense. VEGF, vascular endothelial growth factor, also responsible for the angiogenesis component. Okay, and you'll see VEGF when we talk about certain medications. When we talk about cancer, the big one is bevacizumab, or commonly known as Avastin, that targets VEGF, but we'll talk about that coming up. The other big one, now this is probably the single biggest cofactor here that I want you to remember from the slide, and this is going to be tumor growth factor beta. This is really going to be the kind of the poster child for chronic inflammation and also wound healing to some degree. Okay, so that's essentially chronic inflammation. When we talk about granulomas, it's important to just recognize the big players and be able to identify a granuloma. But a lot of people will look at this and say, look, I've heard this granuloma thing, I just don't get it. Like, what is a granuloma? So let's kind of just go through that really quickly here. Let's look at an image. So in this image down here in the corner, you can see all of these different cells, and you'll see they're kind of all in a circle. And the thing that's in the middle of the circle, that's the pathogen. Okay, so it's essentially what the body is doing is it sees something that's not supposed to be there, whether it's a bacteria, chemical, beryllium being a very classic one. And so the body just doesn't know what to do with it. It can't digest it. It's not doing that effectively. It can't kill it. And so it just walls it off, essentially, and says, look, we're just going to block you off until we can figure out what to do with you. And a lot of times it doesn't necessarily figure out what to do with that substance or bacteria, okay? And so you just end up with this walled off structure that's called a granuloma. And you can see that a lot of the cells around the granuloma are going to be T helper 1 cells. That's all these green cells around here. Okay, so those are T helper 1 cells. We'll talk about what they do in just a second. But they're helping wall this thing off. And then if you go one layer deeper, okay, past them, you can see that there's all of these kind of blue rectangular cells. Those are epithelioid macrophages. And even deeper to them, you can see that we have some other macrophages in the middle here. And then we have some of these really big cells that have multiple nuclei. Those are called giant cells. Okay, so we're going to talk about where all these things come from now that we've kind of introduced it. But when you look at this, if you're looking at this kind of on a slide, you can see what we're talking about, right? You can see all of these cells kind of on the outside here. Let me use a different color here. So you can see all of these cells kind of on the outside back here. Okay, look at all of these cells on the outside. But then as you kind of move in to this thing, there's not a lot of cells here, right? There's very few cells in here. Okay, and that's usually the area that's walled off. And that area, eventually, because it's walled off, right, it's not going to be getting a lot of nutrients and that type of thing. It's not really going to have a lot of cells in that area. And so this is going to become an area of necrosis. Okay, and so this is what we call a caseating granuloma. In other words, it has a core in the center, right? In the center, it's a central necrotic core. The classic things for this are going to be TB and certain fungal infections, like we'll talk about when we talk about histoplasmosis, things of that nature. Okay, but TB is the number one thing to think about when you see caseating or necrotic granulomas. Now, there's also going to be non-caseating granulomas. What does that mean? That means that the center, instead of it being necrotic, it's actually going to have some cells. And you can see here, there's a whole bunch of cells that are in this core here. Okay, so you can see cells pretty much all throughout this. Okay, so there's your core, but then around the core, you can also see that there's going to be a lot of lymphocytes and other tissues. So there's less cells here overall, we'd probably say, but it's not necrosis that's happening here. Okay, so that would be a non-caseating granuloma, an absence of a necrotic core, very classic for sarcoidosis and beryllium. Those are probably the big two to remember. Okay, so notice that these are non-infectious. Now, that doesn't mean that non-caseating granulomas are always 100% non-infectious, but that's kind of an easier way to think about them. So if you're dealing with something that's non-infectious, you can think of, in terms of your big things, it's probably less likely to be caseating, if you had to guess, right? Like sarcoidosis, autoimmune, beryllium, you're talking about more of like a pneumoconiosis type thing. Okay, so that's the principle. Let's just go through this pathway and then wrap things up here. So this is kind of the steps you want to know. You want to know the big players involved. So let's just imagine, right? We have an antigen presenting cell. Let's just say it's a dendritic cell, for example. So we'll talk about all these receptors here coming up. But the antigen presenting cell, we already talked about this. What does it do? It's going to present this antigen to a CD4 positive cell. So maybe it, digested one of these mycobacteria from tuberculosis, and now it's presenting it to this helper T cell. Okay, and we know this is a CD4 positive helper T cell. So we know that it must be binding one of these receptors to MHC class 2. Right, we talked about that previously. Okay, so anyway, it's going to bind here, and the antigen presenting cell is going to say, hey, here's some interleukin 12. Why don't you turn yourself into a T helper 1 cell? So this interleukin 12, okay, is going to help stimulate the CD4 positive T cell, which is pretty much naive at this point. Now it's going to get activated, and it's going to turn into a T helper 1 cell. Okay, so again, antigen presenting cell binds to the CD4 positive helper T cell, plus interleukin 12 turns it into a T helper 1 cell. And remember what we said. T helper 1s, what do? Pro-inflammatory. What are they going to release? Interferon gamma. So here you go. Surprise, surprise. T helper 1 cell releases interferon gamma. What else did I say about pro-inflammatory molecules? Remember, TNF alpha is in that conversation. So interferon gamma, TNF alpha, they're going to help stimulate macrophage activation. You can see that here. Here's your T helper 1 cell, releases interferon gamma, releases TNF alpha. The macrophages that are formed from monocytes, right? You're going to get them to be activated. Okay, and that's all because of interferon gamma and TNF alpha, and we know that because they're pro-inflammatory. Okay, so that's the concept. So you want these macrophages more active because you have some antigen that you identified. Okay, so the T helper 1 cells are helping kind of stimulate that pro-inflammatory response. So the macrophages at this point, now that they're activated, they're going to go after this bacteria, right? They're going to go after whatever it is that this antigen is coming from. And these macrophages, in the process of doing that, will also release more TNF alpha. Remember what TNF alpha is doing. It's kind of your big three acute inflammatory reactants, right? We already talked about them: interleukin 1, interleukin 6, and TNF alpha, right? These are like the big three that are going to be responsible for increasing the temperature and setting off a lot of these acute phase reactants. What happens is, as these macrophages are trying to digest this material, a lot of the times, if we're having a tough time digesting this bacteria and we start wanting to wall this thing off, we start forming these macrophages that actually resemble an epithelial cell. And so they're called epithelioid cells. These are cells that have abundant pink cytoplasm. But it is important to at least understand that epithelioid macrophages are classically associated with granulomas. And these epithelioid macrophages can actually fuse here on the periphery. So you can get two of these or more fusing to form giant cells, where you have a whole bunch of nuclei in one macrophage. And so giant cells are very classic also. And the whole idea is these are essentially just trying to wall this thing off, whatever it is. Okay, and so that's why we're forming these kind of rectangular epithelioid cells and eventually fusing to form giant cells to kind of just block this thing off completely. And what maintains the granuloma? We already said TNF-alpha, these macrophages releasing TNF-alpha, T helper 1 cells releasing TNF-alpha, because we can't break whatever it is down. We're stuck. We're in this repetitive cycle. And the other thing is interleukin 12. So we have a lot of interleukin 12 being released. The antigen presenting cells keep presenting this, saying, hey, we're presenting this thing, but nothing's happening, right? And so this just keeps perpetuating this whole cycle, the TNF-alpha and the interleukin 12. Okay, so those are pretty important cofactors to remember when you're talking about granulomas. Interleukin 12, TNF-alpha.